Yes. Sophia Petropoulou. Hello, Sophia.
Good evening. Good evening.
It's a pleasure for me to see you, and I'm happy to introduce you for the next talk. You were here for 1 year of learning cardiac MRI, and it was a pleasure to work with you all the time. And I'm very happy that you now apply what you learned in Greece, and you have a growing activity. So that's very good to hear. And so I'm very curious to hear your talk. Please, Sophia.
Thank you very much, dear Professor. So, good evening again, esteemed Professor, dear colleagues. I would like to begin also by sincerely thanking Dr. Mavrogianni for the invitation. My talk today is entitled Heartbeat in the Magnet, a New Era for Pacemaker Patients, but my presentation also includes the use of ICDs. So we will discuss the evolving landscape of cardiac MRI in patients with cardiac implantable electronic devices, or CIDs. This is a field that has changed dramatically over the last decades and is increasingly relevant to our daily practice. So our focus will be on 4 pillars: the current indications and contradictions for CMR, the current international guidelines, the safety considerations of performing MRI in this patient population, and the clinical impact and application of ICMR in this population. So before the year 2000, patients with CIDs were considered to have an absolute contradiction for MRI. However, the demand is high. Today, there are an estimated 8 million patients with CIDs worldwide. Between 7 and 17% of patients who receive a new device require an MRI within the first year of implantation. And that translates to roughly 10,000 MRI scans per year being performed in patients with CIDs. Despite this clinical need, the reality is that patients with CIDs are still about 50 times less likely to be referred for an MRI, even when clear indications exist. This is particularly concerning because many of these patients have cardiomyopathies or arrhythmias, conditions where cardiac MRI can provide valuable diagnostic and prognostic information. So while the demand is high, the utilization still lags behind, largely because of safety concerns. So before we go deeper into data, just to clarify some terminology. So MR safe, these are items that pose no known hazards in any MRI environment. Typically, they're made of electrically non-conductive, non-metallic, non-magnetic materials. MR conditional, these are items that have demonstrated safety in the MRI environment, but only under clearly defined conditions. These conditions may relate to the strength of the magnetic field, the gradient fields, or the radio frequency exposure. And MR unsafe, these are items that pose hazards in all MRI environments, such as ferromagnetic objects. It's critical to note that no CID is actually classified as MR safe. At best, devices may be MR conditional, and even then it depends on both the generator and the leads being MR conditional and from compatible manufacturers. Otherwise, the system is not considered MR conditional. So when we talk about performing MRI, cardiac MRI in patients with cardiac implantable devices, we need to consider the specific hazards that arise in the MRI environment. So the static magnetic field can exert mechanical forces on any ferromagnetic component, unpredictably trigger reed switches and alter ECGs, complicating monitoring and triggering. The RF field poses another risk, heating of the lead tip. In theory, this heating can cause tissue injury. Measuring lead heat in the MRI in the MR environment may be challenging and technically difficult and depends on the methods used, explaining why several groups report very different results. RF exposure can also lead to over or under sensing, pacing inhibition, or an electrical reset of the device. The gradient fields can cause excess stimulation and in rare cases induce arrhythmias, especially with unipolar leads. They also carry a risk of resetting the device, even though this is relatively rare. So the combined effects of static, gradient, and RF fields can alter device function, cause vibration, induce resets, and in theory damage the device or the surrounding tissues. ICD patients present their own set of challenges because new generation ICDs tend to experience roughly 10 times greater magnetic force and torque compared with pacemakers, making them more susceptible to displacement or mechanical stress. Another concern is false arrhythmia detection. The MRRF field can be misinterpreted by the device as VT or VF. This can result in inappropriate therapy, cardioversion, or shock. For this reason, shock therapies must always be disabled during the scan. And conversely, the magnetic field can also prevent the ICD from detecting true VA, true ventricular arrhythmias, while the patient is in the scanner. The risk of heating for ICD leads is considered similar to that of pacemaker leads, generally low in clinical practice, as we're going to see next, but theoretically possible. I'm sorry. Also, ICDs are more susceptible to artifacts, as we are going to see. And for these reasons, CID patients must be managed with extra caution and according to very strict protocols. Here we see the European Society of Cardiology's guidance flowchart for MRI in patients with CIDs. So we begin by determining whether the system is MR conditional. If so, and if the indication for MRI is appropriate, then scanning can proceed under standard safety protocols. If the system is not MR conditional, the decision depends on weighting clinical need against potential risks, even in the presence of fractured or abandoned leads. In these cases, MRI may be still performed safely at 1.5 Tesla, provided strict protocols are followed. So to mitigate these risks, structured protocols have been developed. At the time of the referral, several checks must be performed. First, we have to confirm whether the system is MR conditional, and that applies to both the generator and the leads. Then assess the appropriateness of the referral and review the location of the generator, its influence on diagnostic quality, and the status of battery. Abandoned or fractured leads should be identified in advance. Equally important is the establishment of cross-departmental MRI CID team. And on the day of the scan, a full device interrogation must be performed before the patient enters the scanner. For pacing-dependent patients, the device should be programmed into a synchronous pacing mode, such as VOO or DOO. A resuscitation card must be readily available, ACLS-trained staff present, and patients should be instructed to report any discomfort or heating sensations immediately. Continuous rhythm monitoring is mandatory throughout the scan, and specific imaging adjustments are also advised. For example, limiting the SAR to 2 watts per kilogram or less. And finally, CINA imaging with balanced SSFP sequences should probably be avoided, as these are highly sensitive to off-resonance effects. They involve large flip angles and deposit significant RF energy. After the scan, another device interrogation is required to check for any significant changes. Regarding the definition of significant device parameter change, a set of predefined thresholds has been recently developed for conditional devices. These parameters that should be carefully reviewed include the P wave amplitude, the R wave amplitude, capture thresholds, changes in lead impedance, and finally, the battery voltage should also be checked, where even a decrease of 0.04 volts can be meaningful. And all these checks are essential to ensure that the device has not experienced any reset or functional compromise as a result of the MRI. Reprogramming device mode for a cardiac MRI comes with its own potential risks. So for pacemaker-dependent patients, electromagnetic interference can lead to oversensing and pacing inhibition. This risk is minimized by programming asynchronous pacing, VOO or DOO, when no baseline rhythm is present. If a stable rhythm exists, pacing can be temporarily switched off. Asynchronous pacing does carry a rare but serious risk of inducing ventricular fibrillation through an RNT phenomenon, although this has been estimated at less than 0.001%. In patients with ICDs or CRTDs, disable shock therapies is critical to prevent inappropriate shocks. The estimated risk of a true VT or VF event during a 1-hour scan in a primary prevention ICD patient is extremely low for 1 hour of scan. For our CRTP devices, MRI mode typically means RV-only pacing, leading to a temporary loss of biventricular pacing and a mild drop in cardiac output. However, in stable patients, this usually does not cause decompensation. Abandoned or fractured leads are of particular concern, as in vitro data at 1.5 Tesla show that abandoned leads can hit more than connected leads. However, as we will discuss later on, clinical studies so far have not documented adverse events. And finally, early implants are also considered at high risk. Manufacturers generally recommend a waiting period of 6 weeks. Although recent studies have not shown a clear link between early scans and adverse outcomes. Beyond device management, optimizing MRI protocols themselves is critical to balancing safety and image quality. Sequences with a lower SAR should be chosen to minimize RF heating. This can be achieved with lower flip angles, longer repetition times, and reduced duty cycles. Imaging planes should be carefully selected to minimize artifacts over the region of interest, and scan time should be shortened whenever possible without compromising diagnostic quality. Wideband LGE techniques can mitigate over-resonance artifacts, as we're going to discuss later. And importantly, the imaging protocol should remain flexible and adjusted in real time, depending on the severity and type of artifact observed. Here we have some recommendations on technical parameters that could potentially optimize scanning in CID patients, but they are out of the objective of this presentation. But the general idea is that technical parameters across cine, phase contrast, mapping, and perfusion imaging include short RF pulses, low flip angles, and receiver bandwidths above 500 Hz per pixel. Artifacts from CIDs are a major challenge in cardiac MRI. They can be produced by both the generator and the leads and typically manifest as signal voids from dephasing, image distortion from off-resonance effects, or hyperintense regions caused by incomplete RF excitation. These effects are particularly problematic for SSFP sequences. These artifacts can obscure important structures, complicate diagnosis, limit the interpretability. Therefore, protocol optimization and artifact mitigation strategies are an essential part of CMR in patients with CIDs. There are several practical ways to reduce artifacts in these patients. If cine imaging is degraded, GRE sequences are often preferable to balance SSFP. Using smaller voxel sizes, thinner slices, minimizing echo time can help improve resolution. Raising the ipsilateral arm or performing the acquisition in inspiration instead of expiration can move the generator away from the imaging field and therefore reduce signal voids. Increasing the readout bandwidth can reduce frequency encoding distortion. For LGE, perfusion, T1 or T2 mapping, wideband preparation pulses address the limited spectral bandwidth of conventional pulses. So practically in this sequence, we have a wideband meaning a 3.8 kilohertz inversion recovery pulse, which is implemented to replace the standard pulse. And it has been proven particularly effective in clinical practice in mitigating off-resonance artifacts. When assessing ischemia in patients with CIDs, vasodilator stress perfusion is the preferred method as it provides more reliable and interpretable results. Because the butamine stress CMR is less effective because of arrhythmias and pacing-related synchrony. because both arrhythmias and pacing-related asynchrony can obscure wall motion abnormalities. Also, patients with CIDs often have limited heart rate response to dobutamine, reducing the sensitivity of the test. So the question is, after all, how safe is it to perform CMR on CID patients? Abandoned leads are often considered one of the high-risk situations. Disconnected leads, whether caped or not, can theoretically be more susceptible to RF-induced heating. Experimental data have shown that abandoned leads may heat up to 30 degrees Celsius, and abandoned epicardial leads can heat even more, in some reports up to 77 degrees. Despite this, recent clinical studies found no evidence of serious adverse events in patients with abandoned leads undergoing MRI. In this landmark prospective study published in 2017, they examined more than 1,500 patients with CIDs that were not considered MR conditional. They performed over 2,000 MRI cardiac scans at 1.5 Tesla. With reassuring findings, there were no long-term clinically significant adverse effects. Immediately after MRI, the most common notable change was a more than 50% decrease in P-wave amplitude, but this was not clinically significant. Over long-term follow-up, small changes were seen in sensing thresholds and impedances, but none required device revision. This study provided evidence that cardiac MRI can be performed even in non-conditional devices under protocolized conditions. More data supports this position. Lancet colleagues analyzed more than 1,000 MRI studies in patients with non-conditional leads, abandoned or epicardial leads, and even lead fragments. This was a very diverse group. No deaths, no serious malfunctions such as generator failure or loss of capture, no inappropriate inhibition of pacing. Patients did not report discomfort, palpitations, heating, or arrhythmias in the 24 hours after scanning, and this provided further reassurance that even more complex device scenarios can be managed safely. A large meta-analysis covering more than 5,000 patients, again with non-conditional CIDs, scanned at field strengths between 0.5 and 3 Tesla this time. There were no deaths documented, no ICD shocks attributable to MRI. The most common complication was electrical reset, followed by heating or torque-related symptoms, inappropriate pacing, but generator failure. The analysis also highlighted that in clinical practice, nearly 90% of devices in use are non-conditional. Therefore, safety data in this group is of direct relevance to daily practice. Looking in more detail at lead parameters, we observed that while small parameters shifts can occur, they very rarely translate into clinically meaningful events. And finally, regarding ICD patients, this was the first randomized trial on CMR and ICD patients in 2015. This was a multi-center study where patients with ICDs underwent MRI at 1.5 Tesla with SAR levels up to 2 watts per kilogram. Some patients even underwent VT induction testing post-MRI. The results were again positive. The primary safety endpoint was met with 100% of patients free from MRI-related adverse events at 30 days. And the efficacy endpoint was also met, like pacing thresholds and sensing parameters were preserved. So as electrophysiology, cardiac MRI has particular applications, but also unique challenges, as very elaborately analyzed in the previous presentations by the previous speakers. There are some special considerations regarding CID patients. Standard LGE often suffers from low diagnostic quality due to artifacts from the generator. Patients with high arrhythmia burden may also show ghosting artifacts on segmented 2D or 3D sequences. We may face unstable situations, such as situations in high risk of occurrence of VT storm or VF, where protocols may need to be shortened to the essential sequences, for example, only LGE. Moreover, epicardial leads are not MR conditional, but in practice, many centers have performed MRI in such patients without adverse events. And for left atrial imaging, 3D LGE is also affected by artifacts. Wideband late gadolinium enhancement sequences significantly reduce artifacts from generators and allow reliable scar visualization. It is considered the technique of choice for scar detection and VT ablation planning, even when arrhythmogenic substrates lie close to the device. Multi-parametric protocols have also been shown feasible in ICD and even subcutaneous ICD patients. And this means that we are able to obtain accurate scar and fibrosis characterization in patients with CIDs. Importantly, the presence of LGE and CMR in this specific group of patients is of high diagnostic importance. In this study, CMR on CID patients modified the initial diagnosis in 36% of patients. And also it provided valuable prognostic information. These imaging advances directly impact how ablation procedures are managed. So in this study, wideband CMR in ICD patients showed at 85% concordance with electroanatomical mapping for identifying scar channel entrances. This means that even in patients with CIDs, we can use CMR to define the arrhythmogenic substrate and guide the ablation strategy. And the practical benefit is clear. CMR provides a roadmap before the EP lab, as very elaborately discussed before, helping to target right regions, reduce unnecessary mapping, and better understand whether an epicardial approach is needed, even in CID patients. And looking forward, combining pre-procedural CMR with electroanatomical mapping is already feasible. The next step will be true interventional CMR ablation in patients with CIDs, an area where strong evidence is still lacking. So in the field of real-time interventional CMR on patients with CID, there are not enough data. To my knowledge, there have been no published studies where ablation was performed under real-time MRI with an ICD or pacemaker in place. Even though this is a population where quite often there are clear indications for electrophysiology procedures and a population that would greatly benefit from them. However, until now, most real-time CMR guided ablations exclude these patients because of artifacts and safety concerns. So despite all the progress, we have some gaps that remain. So while safety is well documented at 1.5 Tesla, we need more outcome data and recommendations at 3 Tesla, especially for non-conditional devices. There is still limited evidence regarding ICMR in CAD patients. And finally, we must address the barriers to access. Despite strong evidence of safety, many patients are still denied the MRI, cardiac MRI, because of outdated policies or lack of infrastructure. And overcoming these barriers is crucial. So to conclude, CMR is safe for most patients with CIDs. This position is endorsed by major societies. And future directions include developing solutions for interprocedural applications and increasing access to MRI. Thank you very much for your attention.
Thank you very much, Sophia, for this excellent talk. Good overview of what can be done and where are some gaps that should be filled. Very good talk. Thank you very much. Maybe before we go to other questions, I just wanted to add one thing before I forget it. You mentioned the 6 week, the 6 weeks pause after implantation. This is just because when we started to do these studies on with Medtronic for these EMA and FDA approvals, Medtronic wanted to make sure that the lead is completely implanted and the healing process is over, so that after 6 weeks they know it was clear from the data that they had that the healing process is over, and the lead threshold for capture sensing will be stable, because then only they wanted to test the impact of imaging, of MR imaging on threshold, capture threshold, and sensing thresholds, and not to do that during the healing process. There was no doubt that it would be safe just the day of implantation or 2 days later. It was just to make sure that the trial will be okay, will be positive, that they wanted to exclude these 6 weeks. Yeah.
I see. Okay, thank you.
May I? Yeah, thank you very much. So, Dr. Petropoulou, I enjoy very much indeed your presentation. Very well documented. And as I am working in this field, I would like to comment first that we have to individualize all these persons very carefully. Especially attention is needed for all those pacemaker patients who are completely dependent from the pacemaker. This is one of the main concerns, okay? So if I had to individualize these patients with pacemakers, for me, the most, let's say, very difficult situation will be if the patient is completely dependent from the pacemaker. It's totally different if I am dealing with one patient without any dependence. In general, you presented very nicely what exists in the literature. But with the highest respect to you, I have to confess that I was expecting to see, this is a kind, let's say, humoristic approach than a blame, to see a more recent study, big study, published in our flag journal, European Heart Journal 2021, under the title Evidence to Support Magnetic Resonance Conditional Labeling of all pacemaker and defibrillator leads in patients with cardiac implantable electronic devices. At the same issue, I had the honor to write the an editorial under the title Reconsidering Safety and Reducing Barriers to MRI Patients with Cardiac Implantable Electronic Devices. This editorial was written by Chiara Bucciarelli Ducci in London and myself. The first study, the original one, included a lot of patients. It's coming from London. Anis Bouva is the first author, and Penel and others are included there. The main message here is that there was no increased risk of MRI in patients with non-MRI conditional pacemaker or defibrillator leads when following recommended protocols. You said the same, more or less. Standardizing MRI conditions for all leads would significantly improve access to MRI by enabling patients to be scanned in non-specialistic centers. And in the conclusions, this study was clearly saying that there is no incremental risk of either clinical safety events or early changes to device or lead performance from 1.5 Tesla MRI for patients with non-MRI conditional pacemaker or defibrillator leads compared with those labeled MRI conditional when approved protocols are followed. So, and this study from London includes thousands of patients, and it is something that I humbly suggest to be included from now on in your, let's say, papers.
That's with pleasure.
I would like to add something to that, Panos, because you really mentioned something which is deep in my heart. And I'm happy that you say that you considered the risks. I was heavily involved in the studies that tested the first conditional MRI pacemakers and the first MRI conditional ICDs. So I spent like 8, 7, 9 years heavily involved with almost weekly phone calls, etc., to design these studies. So I put a lot of work into these studies to prove that conditional MRI, conditional devices can be used. And I'm not a big fan of this MagnaSafe study in the New England Journal of Medicine. They had included 1,500 patients. That's a lot. But if you look how many different devices they used, the brands of the devices, you see that they had about 30 or so devices, pacemaker, and 17 patients per ICD device. So if you take 17 patients with a certain device, you put them into the scanner and they have no problem, you cannot say that they are safe. You would never take 17 patients with a drug, you treat them, and if they have no complications, you would say 17 patients is enough to say this is safe. We cannot do that. You mentioned that this is 1,500 patients, but these patients cover all the different devices that are on the market. This is like if you would do a drug study with 1,500 patients, and you would say if there is no signal of complications, all drugs in Europe are safe. You must test every drug, whether this drug is safe. You must test every device, whether this type of device is safe. This is my personal opinion, but I would like to have more strict rules in that, and to say if there are EMEA and FDA approved devices, they are conditional. So under certain conditions, they are safe, and not tested devices cannot fulfill these criteria. 1,500 patients is nothing compared to 750 million people in Europe. It's a little bit provocative, but
yeah.
I don't like this study really.
Okay. Can we move to the discussions, just because we overcame the time? So I think